Catherine earned her Doctor of Optometry from the Southern College of Optometry and completed a residency in ocular disease at Baskin Palmer Eye Institute in Miami, Florida. She's a fellow of the American Academy of Optometry and an active member of the American Optometric Association, currently serving on the AOA's Coding and Reimbursement Committee and the Pinellas Optometric Association Board of Trustees. Dr. Catherine is actively involved in FDA clinical trials and serves as a glaucoma subject matter expert for the Center of Medicare and Medicaid Services, CMS. In 2023, she was awarded the AOA President's Award for her contributions to the profession. And Dr. Catherine lives in St. Petersburg, Florida, where she specializes in the medical management of glaucoma and neurological eye diseases at the Eye Institute of West Florida. And here are her financial disclosures, all of which have been mitigated. And so without further ado, I'd love to turn it over to you, Dr. Catherine.
Awesome. Thank you so much for that fantastic introduction. Now, let's see if I can share screen. And so we want to share this screen. Here we go. And right now, you should be able to see the full screen of the title slide. Hopefully that's coming up. Okay. Second time is a charm. Let's see here. Let me go here. Okay, that's up there. All right, share screen. There we go. Share. There we go. Share screen. Now, oh, that looks familiar. Let's see. Perfect. And share. And here we go. Now, hopefully we should see the title slide.
Yes, ma'am.
Excellent. Thank you. The magic behind the screen is going to minimize my video. I'm still here. I'm coming live to you from San Juan, Puerto Rico, and I'm on a little bit of a vacation, but we still have internet. But just in case it's not as high speed enough, I want you to be able to see the content of the slides, and you can still hear my voice throughout the presentation, and then I'll come back on the screen at the end of the presentation. So tonight we're going to talk about my favorite topic, glaucoma. The interventional mindset, managing glaucoma in 2026. The way we manage glaucoma in today's day and age is fundamentally different than we did 5 years ago, 10 years ago, even, definitely 15 to 20 years ago. But the speed is changing at which we have tools in our toolbox and the ability to manage the disease. These are my financial disclosures. All of these have been mitigated. This CE activity was planned and prepared by me. These are our course objectives. All right, tonight we're going on a road trip. I know many of you are at your homes, in your offices, maybe listening to me in your car as you're commuting, but we are going on a road trip. And just like any road trips, there's stops all along the way. The journey is the most important part. And we're going to learn how practicing with an interventional mindset will help you help your glaucoma patient, regardless of the modality that you practice in or the type of glaucoma patient that you care for. So grab your mixtape and some snacks, and let's hit the road. This is an overview of what we'll discuss today. And the first thing we'll talk about is the landscape. Just like any road trip that we're going on, we need to understand the landscape. And with the relation to glaucoma, this is talking about the background of the disease. What is glaucoma? Glaucoma is fundamentally a family of optic neuropathies. There is an anatomical and a vascular pathogenesis, potentially a metabolic one, an autoimmune and inflammatory. Maybe in our lifetime we'll see something, but ultimately it is the neurodegeneration of cranial nerve 2. The most important cranial nerve in the body, but I'm obviously biased. Glaucoma impacts 4.2 million Americans, and that number is expected to double within the next 20 years. We know that there's a genetic component to the disease, and one of the saddest things is this disease, it impacts a disproportional portion of our population, our African American and Hispanic friends and neighbors, those of our patients that have poor health literacy, and the unemployed and the disabled. And one of the saddest statistics that I've come across in my decade of clinical practice comes from the public health literature. And it's patients with severe vision loss. They not only suffer from higher rates of anxiety and depression, but they also suffer from higher rates of all-cause mortality, meaning their lives are shorter. So as optometrists or optometric physicians, this is a disease that in all 50 states we can now actively manage. And we have the capability to do something to impact these patients' lives, to preserve their sight. Refractive care is the bread and butter of our profession, but what's the point of having a good refraction if the cable that's conducting the information to the brain isn't fundamentally working? And when it comes to the pathophysiology of glaucoma, we're understanding more and more year over year, and with our greater understanding of the genetics behind the different aspects of the disease. This is a nice, beautiful image that I love. It's one of my favorite. And it's just a reminder that the aqueous is produced in the ciliary body at the pars placata and flows through the zonules, up and around the lens and over the top of the iris, and comes over into the anterior chamber. And the primary outflow of the aqueous is at Schlemm's canal, or is at the trabecular meshwork. And the secondary outflow, or the non-traditional pathway, is Schlemm's canal. I always think Schlemm's canal because it's the first category of the outflow system that we actually had a drug to target. But now, thankfully, on the market, we have drugs that target all aspects of aqueous outflow. The trabecular meshwork, the place that is responsible for the highest percentage of aqueous outflow, is actually the primary source of dysfunction in glaucoma. Oxidative stress is extremely important with regard to the role that it plays in vascular dysregulation, and it can actually damage ganglion cells. Preventing the structural damage at any level is the ultimate goal of therapy. And so this is the reason why at the end stages of the disease, a lot of drugs that are target the trabecular meshwork don't work. Because if you look at the right side of the screen, you see this trabecular meshwork. It's like flexible, springy rubber bands, because this is like living, breathing tissue. And once it's undergone oxidative stress, you can see that it looks brittle and frail. And so you can't have active movement in a tissue that is fundamentally scarred. And so the goal of glaucoma management is to prevent the snowball from turning into the avalanche. And as optometrists, we had up until the 1990s, there were very limited, even in states that could utilize therapeutics, there were limited amount of options that were there. With the advent of the prostaglandin analogs coming on board, we had more tools, but now we have the ability to target the fundamental dysfunctional area. Glaucoma is an all-hands-on disease that we all have to work together to help manage. This is one of the key take-home messages, are these next two slides. If you take anything away from this slide set, these two slides are it. Not all glaucoma patients have higher than average pressure, but the baseline intraocular pressure in every glaucoma patient is too high for that particular eye. And when I explain it like that to patients, they really do understand, and it seems to resonate, because everyone thinks glaucoma is this high eye pressure disease, and it's not. Not all patients that, in fact, over 50% of patients that have glaucoma are thought to have some form of normal tension glaucoma. And so their IOP is not starting out higher than the average pressure, but it's too high for that particular eye. So anytime we're going to go on a trip, we need to plan. And that's where interventional glaucoma comes in. Interventional glaucoma is something that you may have heard over the last few years, especially in the post-pandemic realm, in attending CEs and hearing more about glaucoma, but it's actually more than a buzzword. In working with doctors that practice IG and consulting for companies that champion IG, interventional glaucoma is a practice mindset or attitude. It places an emphasis on early intervention and active monitoring. This is not wait until the house is on fire to call the fire department. This is to prevent the fire from burning down the house. This is a shift toward proactive care versus reactive care. And the reason that we can utilize reactive tools in this proactive way is because before we had a limited amount of tools to be able to use. So although a lot of docs think of IG, they're like, oh, you're an optometrist. Why are you talking about interventional glaucoma? That's a surgical thing. And it's really not. IG was thought to be, procedure centric, but it's truly not. This is a quote from Dr. Ike Ahmed, one of the, I call him a modern godfather of glaucoma, but he's my age, but my mindset is the key word, because this is bigger than one procedure or one technology. So, here's one of the most famous glaucoma surgeons that is practicing these days, that is really championing this mindset, the mindset, not a surgical technique, not a surgical procedure, but it's a mindset. Tenets of interventional glaucoma include techniques that are evidence-based, mindsets and strategies that mitigate non-compliance. They include sustained release, and again, proactive early intervention is what we're focused on. The goal of interventional glaucoma is to stop the fire when it's on the stove and put the lid on the pot before it burns down the house. Because I'll tell you, sometimes when I see these cupped out nerves, I feel like that firefighter that's standing in front of that building. Nothing that I'm going to be able to do as an OD, and even a lot of my surgeons, there's not a lot that they can do. There is nothing we can do to repair what's lost. But oftentimes, once the optic nerve is so frail and so fragile, even a tube shunt procedure or a surgical filtering, excisional surgery filtering procedure will eventually scar in time, and that patient has a limited amount of vision that's left. And so I never want to see a patient get to the point where I'm talking to them, explaining them, you need surgery. If you don't have surgery, you will lose your vision. And if you do have surgery, you may lose your vision while you're having surgery, because the vision loss is so severe and the nerve is so damaged. So as optometrists, it behooves us to treat early, to treat aggressively, to prevent the patient from ever needing to go into the surgeon's chair. And that's something very cool that I couldn't say prior to 2017, but I can now. Managing glaucoma with an interventional mindset means that you take the patient out of the driver's seat, you buckle them into the passenger seat, and you, the doctor, take the wheel. And so as you go along on a road trip, you as the doctor are in the driver's seat. We relied a lot on patients being in the driver's seat and us giving them recommendations on how to manage their road trip. And there are a myriad of factors that we'll discuss later in the lecture of why patients aren't good in the driver's seat of managing their disease, especially chronic progressive diseases like glaucoma. So as we're packing for our trip, we want to talk about what we're packing along with us. And one of those things is data. Data is beautiful and incredibly powerful. This is something I felt my entire life, even prior to optometry as a data analyst for the DoD. I love data. And I love now that we have volumes and volumes and volumes of beautiful papers that are written, a lot of neat long-term studies, extension studies of trials, head-to-head studies. Really, a lot of data has come out within the last decade, and it's been thrilling to review and to apply to clinical practice. And so my job as a lecturer is to analyze this data for you and bring to you some of that data and how it's clinically relevant. And one of those sets of data is the ocular hypertension treatment study. This was a landmark study, and it looked at, there were a 10-year data set and a 20-year data set. And the risk factors for primary open-angle glaucoma progression from ocular hypertension were isolated out: IOP, CD ratio, patients that were Black and Hispanic, pattern standard deviation, central corneal thickness. And in the 10-year data set, it showed that topical medication delayed or prevented POAG onset. The initial data set, I misspoke. The 10-year data set actually looked at risk stratification. This is where we get our high and our low risk patients. And that data set said that these two categories may aid in disease management. The 20-year data set told a different story. And this actually fundamentally changed how I manage these patients. The 20-year data set showed that Dr. Cass and his colleagues tracked down every living member of the OATS study and found that over 55% of African-American patients converted from ocular hypertension to POAG, and a fourth of those had irreversible field loss. There was another set of data that's outside of the OATS study that was an independent paper that showed that polygenic risk score was an independent risk factor of the OATS patients of progression from ocular hypertension to primary open-angle glaucoma. Ocular hypertension is no longer a wait and watch disease. When you look at the 20-year data set and you see 55% of Black patients converted to POAG, I have very, very different conversations with my ocular hypertension patients. If I have a 40-year-old Black patient sitting in the chair who had a mom or a dad that went blind from glaucoma, I talk to them and I say, look, you have the high pressure, like your parents or parent, And right now, you don't have any damage to your optic nerve. We can treat with a laser or treat with an interventional, an interventional tool to lower the pressure and lower or mitigate your risk of progression, or we can wait and watch. And of all of those patients, when I have that conversation, now understanding this 20-year data set, almost every single one of them chooses to treat. There is a psychological, I don't want to say trauma, but I will call it trauma that comes along with watching your parent lose vision and become dependent on you over time or dependent on others. And it's heartbreaking. And a lot of the patients that have experienced that, especially those that are my age, don't want to see that, happen to themselves. So they are able to make the decision that they don't want to wait and watch. The LIGHT study was a study that looked at laser as first line. It looked at cost, efficacy, and safety. These are three factors that up until this point weren't actually all three of this triangle of factors evaluated in a clinical study for a glaucoma intervention. And it was also one of the first large glaucoma studies that looked at quality of life on, a patient's life as they moved forward with this progressive disease. And what the study found was that patients that received SLT as first line, they exhibited disease stability with greatly reduced cost burden. This is so important in our day and age. Going back to the previous study we just talked about, if I've got a patient that's 40 years old that has ocular hypertension, we are a country now that ties our insurance to our employment. So if a patient loses their job, they don't have the ability to come back for their annual, glaucoma follow-up for OHTN, or they may move. There are life circumstances that we can't predict. But what we can do is put a life jacket on those patients. And in the same way, putting a life jacket on the ocular hypertension patients that have SLT as first line, they have disease stability and a lower cost burden. I had a patient that they were an ocular hypertension patient. I was seeing them back for some follow-up testing. I see them, annually, and they told me, they say, look, I'm going to lose my health insurance because I lost my job and I won't have health insurance by the end of the month. And so what we did is we brought them in and we did a DSLT on each eye and we did a Durista in each eye, and the patient's pressure went down by 61%. And now I can put them out in the world, and I don't know when they're going to have employment again or when they'll have health insurance, but at least I know that I've duct taped a life jacket onto that patient. The American Academy of Ophthalmology and the European Glaucoma Society, they all recommend SLT as first-line treatment for POAG now. As you watch the screen, you'll see the different drug classes move across the screen, but the main thing I want you to look at is the difference between the time period between 1997 and 2017. And this is a 20-year gap between a new drug class. And there are very few serious disease states that I'm aware of that went 20 years without a new class of medications. So 2017 was really the start of a golden era, actually a little bit prior to that with some of the MIGs coming on board, but the golden era of glaucoma. We have two drugs that came onto the market that work directly within the trabecular meshwork, and it was really game-changing for optometry. So we're not going to cover everything. We're going to cover the newest approved ones and those that you may hear that are on the market, and we'll cover two investigative drugs. I never want you, as a colleague, to hear about a drug from a patient without hearing it from one of your colleagues in the lecture circuit. It's our responsibility to you to deliver you this information and to make sure that you are updated on what's out in the space. Ropressa is the name brand for a medication called Notarsadil, and its sole mechanism of action is within the aqueous outflow. It works within the traditional pathway, and it can actually lower episcleral venous pressure by up to 10%. It was the first new drug class in 2 decades. Rho kinase inhibitors, they have been used for years to treat cardiovascular conditions due to vasodilation, and they reduced inflammation. Some of the corneal common side effects that you need to know about: the corneal verticillata, you may see it on the corneal in the cornea. It looks almost like the amiodarone whorls that come from amiodarone. They do not affect vision. Conjunctival hyperemia and petechiae, these were in over 50% of patients in the clinical trial. To many patients that have never had pressure controlled as low as they are on these drugs, they are not significant to the patient. They are more bothersome. The studies show they are more bothersome to the doctor than they are the patient. So I have open communication with the patient. Hey, your pressure's 8. I understand, your eye is a little red, and the patient looks at me and they're like, I don't care about that. I've never had a pressure that's 8 before. Let's keep using this medication. So it's important to have these open conversations with your patients and involve them and let them play an active management in their care. Just don't let them take the wheel. Something that is very rare that wasn't in the initial, AEs from the FDA was reticular bolus epithelial edema. I've seen 5 of these just in my years of using this drug. And the nice thing is it's completely reversible. It almost looks like this kind of very unusual kind of like corneal honeycombing is what we nicknamed it. But once you remove the drug, the cornea is so resilient and it heals beautifully. So in the picture on the right, you'll see a patient that had this reticular honeycombing in below. Once the medication was removed, you can see how clear the cornea went. I was a principal investigator for a phase 3 study that looked at a reformulated version of the fixed dose combination rocklatan, notarsidil, latanoprost with that would have less hyperemia. And I am looking forward to that top line data coming out. So it should be hot off the press here, probably within the next year. Vyzulta is another medication that was FDA approved that same year. It is a nitric oxide donating prostaglandin analog. Nitric oxide is an endogenous molecule found throughout the human body, and it's actually, patients have glaucoma have been found to be 40% deficient in nitric oxide metabolites. My colleague Connie Okeke and I, we published a retrospective chart review in clinical ophthalmology that found that patients that were on a prior PGA and we switched them to LBN, they conferred an additional 25% pressure lowering on top of what they were getting from the PGA, and that was attributable to the nitric oxide. So we searched an even broader set of data and got access to the IRIS registry data. And it's a repository of data from all over the United States, major academic institutions. And it actually found that, I jumped the gun. We found that patients that were switched from a PGA achieved an additional 2.4 millimeters of lower IOP. And those that were on fixed dose combinations got an additional 3.2. So a patient, this is attributable, we presume, to the nitric oxide, but it's just really important to show that as an optometrist, if you see something clinically, you have the capability to help to generate data sets that can help everyone understand a disease state or a therapeutic molecule. Omlanti is a very unique molecule. It's been approved in Japan since 2018. How it is not associated with PGA periorbitopathy. The patient on the left, you can see the right side of the eyelid has been on a PGA for 20 years. The left side has had a trab, and you can see that the patient's eye that has been on the PGA has this fat recession and periorbitopathy. However, there's not as widespread U.S. availability as hoping for, and we're unsure about the coverage from payers, meaning insurance companies. Iuze was FDA approved in 2022. It works within the uveal scleral outflow. It's the first preservative-free latanoprost. I put that asterisk there because we do have preservative-free tafluprost, and that's on the market as well. And this was not covered by insurance, specialty pharmacies, and it's not any more efficacious than latanoprost, but it does give you a preservative-free option for your patients that need that with ocular surface issues. And Zolimbus is on the market now, and that is a preservative-free bimatoprost, and it's a gel formulation. Again, no greater statistical efficacy than bimatoprost, but it is preservative-free, single-use vials. And as of right now, it looks to be unlikely to be covered by managed care plans, so you may need to coordinate this with specialty pharmacies, but it's out there. We're going to talk about 2 investigational drugs. The first is NCX 470. Nycox was the company that created this, but this is a drug that is now under distribution rights of Kowa Pharmaceuticals America, K911. Nitric oxide donating bimatoprost. The Dolomites and the Mont Blanc studies showed nice efficacy. The Whistler 3B study investigated aqueous humor parameters that were stimulated by nitric oxide, and it showed that they were statistically significant. Because there were members of our optometric community that kind of, poo-pooed on the idea that nitric oxide was even working within these molecules. And so I wanted to see the data, and the data set's there, and it is nice. They actually also investigated to see if EVP was impacted by this molecule, and it was not. The Denali top-line data was shared at AGS in 2026, and I will actually be presenting the top-line data for the Denali study at the American Academy of Optometry this fall in Anaheim to the optometric space. So I was a PI for this investigation as well, but I am very, very excited. The new drug authorization was submitted this summer. This is a molecule that could be commercially available to you next year. This is the next hot thing, QL111 by a company called Cularis Bio, the ATPase sensitive potassium channel opener. And these types of channels have been identified across multiple tissues, just like those nitric oxide, just like Rho kinase. And the EVP used to be the lower floor of where we could take pressure with topical hypotensives. This is a drug that targets all structures distal to the TM. So if this would be FDA approved, this would work in addition to Repressa. Repressa works at the level of the TM and maybe a little in the episcleral outflow, but this solely works within the episcleral outflow. This phase 2 data is some of the nicest that I've seen. There were no notable tolerability or toxicity issues. And the Nightingale study is a phase 2 study that only enrolled patients with normal tension glaucoma. Those results should be available within the next year. And the phase 3 study should be enrolling soon. So stay tuned to your local areas. If you have patients with normal tension glaucoma, primary opening glaucoma, ocular hypertension that may be clinical candidates, you can find a site that may be enrolling. Now, let's talk a little bit about the surgical timeline. Very similar to the topical therapeutic timeline. The surgical timeline was somewhat stunted between 1979 and 2000. So, almost 20 years, there was not a substantial new thing in the world of surgical glaucoma. And in 2012, trabecular stenting, a company called Glaucoma created something called the iStent. And it really did kind of kick in the door for a bunch of companies to start investigating other avenues. And it really did usher in the era of MIGS. What are MIGS? MIGS are minimally invasive glaucoma surgeries. The key features of all MIGS are their assets. I came up with this acronym because these little they're tiny but powerful. And every single one of these tiny procedures is an asset to the glaucoma surgeon. They're performed ab internal, they're safe, there's a swift recovery time, they're efficacious, and they involve minimal tissue disruption. They can target both the aqueous production, but the majority of the newer MIGS target the aqueous outflow. And they can either augment or oftentimes replace topical therapy, which is what I love. The old paradigm, the old thought process was drops, laser, surgery, and MIGS was somewhere in between the laser and the surgery is when docs were employing MIGS. And now that's the old mindset. That's why we're throwing it in the trash. This is the new mindset. We have laser first. We have drops along the way. We have surgery at the end stage if it's needed, not when it's needed, if it's needed. Because minimally invasive glaucoma surgery, these MIGS can be employed any place along the patient's glaucoma journey. And even you can see where I've overlapped that band, even in front of the laser and even after the incisional glaucoma surgery, like tubes and shunts. So our thought about how we're employing MIGS has really shifted. Data drives the evidence-based nature of paradigm shifts. So now we have all of the things in the toolbox. We've got all the stuff in the car. Now we're on the journey. When you diagnose a patient with glaucoma, this is the most important part of the patient's glaucoma journey. It's not deciding what drops you're going to use. It's not deciding what surgeon you're going to send to. It's mitigating some of the psychological shock that these patients face, because reactions to sight-threatening diagnosis are going to really vary. Some patients will say, okay, doc, what's the next step? And other patients will break down in the exam chair. And you really do have to make sure that you address the fact that the risk of going blind in today's day and age is minimal, honestly, to have functional blindness, depending on where the disease state is caught. One of our landmark glaucoma studies found that not addressing blindness was, a driving factor of patient confusion in the beginning of the diagnosis. So I actually feel very comfortable telling patients, look, this does not have to be a blinding disease. This is a disease that can be actively managed. There's no cure, but we can work together and we will find a solution to keep your pressure at a safe place so that we can mitigate field loss. And that is 100% truthful. So these are a few do's and also a few don'ts as you are diagnosing patients and discussing with them. I like to use a medical model of the eye and show it to them I like to give them something to take home. I like to provide them assurance. And it's really important to understand where their fears are. Taking the time to explain this diagnosis is really critical to building trust and laying the foundation for a strong patient relationship. Those that are in my local area or know me, I have almost 100% show rate in my clinic, and we're the only ophthalmology practice that takes state Medicaid, where sees glaucoma.
I think we may have temporarily lost Dr. Cawthorn there for a second. We'll give her a minute to hop on back. Dr. Cawthorn, are you back with us? Yeah, we're going to continue. We're just going to wait for Dr. Cawthorn to jump back on. I know she was in Puerto Rico, so she may just have some poor signal. Thank you, everybody, for your patience this evening.
Questions in the chat box, because when I'm in the full screen mode, I actually can't see the chat box.
Oh, we can hear you now, Dr. Cawthorn. Go ahead, take it away.
Okay, cool. I just want to make sure there were no questions in the chat box.
Oh, you do have a few questions. You want to take those now?
If they are up to this point in time, I'm happy to.
Yeah, there was a question about if Repressa can lower IOP so much, is there a point where the pressure is considered too low that would be of concern?
Gosh, that is a great question. And actually, patients ask me that. So Repressa on its own, the Nutarcidil, has the ability to lower pressure by about 20% on its own. When you combine it with a fixed dose combination medication, in a fixed dose combination with a medicine like latanoprost, like a medicine called Rocklatan, I found that you can get about 40%, 45%, sometimes 50% pressure reduction. Now, the nice thing is about the eye and the aqueous system is that it will set a lower floor for where you can go. And prior to Repressa, that floor was EVP. But remember, Repressa can only lower like below EVP 10%. So some patients will get to 8, 7 if they're on the fixed dose, or if they're normal tension, they're only on it. But there's a little bit of a built-in buffer where you can't get any lower than that. Now, with the addition of a drug like the Cularis drug, it's a possibility to go even low. But honestly, unless I'm seeing choroidals, and even if patients have tubes and shunts, I don't really get nervous unless the pressure gets to like 2. But the drug itself can't move you below, I would say about 7 or 8 is the lowest that I've seen it move. And that's in combination with the PGA. That is a really good question. So it's like a soccer ball. A soccer ball, you have a lot of air in it. And even if the air is leaked out, you actually have to physically push the ball back to get it to deflate.
The next question was about Zolimbus. How many drops per vial and how many doses per day?
That is an excellent question. I am unsure about the drops per vial, but I know that the company does put enough drops. So if the patient misses their eye, there are additional drops within the vial. Most of these vials that are of the preservative-free PGAs, they usually have, I would say, 6 to 8 nice size drops within the vial, because if a patient misses, because of the viscosity of Zolimbus, I actually haven't counted out. I have some samples at work and I actually will do that. So I'll have that answer to be prepared for the future. but it is once at night, just like a prostaglandin, and it does need to be discarded. Because remember, when the drops are preservative free, there are no preservatives to keep the drug safe within the vial. Here in Florida or in any humid environment, it can turn into a science project. So I tell patients to follow the indication, put 1 drop in at night, and then throw the vial in the trash. But there are extra vials for sure. If the patient does miss their eye, they're not going to run out of medicine.
The next question was for MIGS. Will CMS only pay when MIGS are placed during cataract surgery?
Oh, we are about to get there, so hold tight for that answer.
The next question was, how much weight do you put on trend analysis showing ganglion cell layer and or nerve fiber layer loss on OCTs? I have the Maestro 2 with OCTA. How much loss is significant? Maestro flags loss with p-values when appropriate if you have at least 3 comparison scans.
Yeah, so I do like the ganglion cell analysis and guided progression analysis. I usually don't run them automatically on all my patients, but I will run them if I am seeing some change in the field that has me a little concerned, or something that I see unusual in the nerve. We have to be careful with some of the guided progression analysis, because if a patient, say, has, like, I had a patient that had like an NAION, and then it bottomed out their whole hemisphere of their RNFL, and it really did significantly impact, what that RNFL looked like. So when we look at the RNFL, we can't use it in isolation of just glaucoma alone. We have to think of anything that could affect the nerve. Or say a patient has a drench hemorrhage, and that drench hemorrhage is going to get dropout at that aspect, and you're going to watch that chart dip down. But if it's stable afterwards, so you may have to start resetting where you're looking at your guided progression analysis, just to be safe. But I think that there is value for it. It's just about deciding, if you are suspecting that like a patient is progressing, then I think that there's no means. And in looking at that, a patient should lose a few microns per year from normal aging. But these instruments that do this guided progression analysis, as you watch that start dipping down, and it's a little different than if Mima at 91 years old has a little bit of RNFL loss versus, your colleague down the hall who, is, running your OCTs, and that 29-year-old technician has a significant amount of loss. So we have to kind of use the data, understand the data, that it is valuable, but then decide on how we change our clinical path or the clinical journey for that patient, if we change it at all.
Last question here is, someone says they know of a patient who has a cyclodialysis cleft as a result of cataract combined MIGS surgery gone wrong. Now they suffer from hypotony. This seems to be a rare surgical outcome. I'm wondering if you've ever seen this in cone management, and what was the long-term management outcomes were.
So I have seen these collapsed clefts, not in my own practice. Thankfully, those patients have moved from up north and come and join me, and then I have the joy of managing the aftermath. Patients that do, suffer from hypotony. So patients can have low pressure without hypotony. And so if a patient has a pressure of 3 and everything's fine and there's no hypotony, I would put low pressure, no hypotony. But if they do have hypotony, there was a paper that was actually presented at the American Glaucoma Society about, I think it was 6 years ago. And it was a podium talk. And the doc had patients sleep with a Fox shield for 6 weeks that had hypotony, just to see what would happen. And interestingly enough, the patients that slept with the Fox shield, their rates of hypotony actually were not at. They were the presence of their choroidals and their hypotony changed just enough that some of them actually gained a little bit of functional vision, but the IOP actually changed and went a little higher. Some docs have done prednisone and put prednisone to try to induce a steroid response in some of those patients. I have seen that work before in patients that are known steroid responders, to just get the pressure from 2 back up to 7 or 8 or 9. But I think the aspects of that type of management are just a little bit complex for this particular course. But I would be happy to include these types of things in maybe a course at the AOA or the Academy of like kind of surgical aftermath gone wrong, and like options, not gone wrong, how about not ideal. And we can talk about the ways that we've managed them successfully. But having the patient sleep with a Fox shield, there would be no downside to try that.
Those are all the questions for now.
Perfect. Let's talk about stormy skies and the treatment that we decide for our patients. So we're in the driver's seat. How do you decide what to do? We talked about laser as first line. There's a new laser that's out there. It's a newer flavor of laser, the same concept of the SLT, but it's a DSLT, the direct selective laser, trabeculoplasty. And this is a laser that does not utilize a gonioprism. It delivers the energy directly through the sclera. I was proud that my practice was the 4th in the United States to acquire this device. I have very progressive surgeons, very optometry friendly progressive surgeons that I work with. And we have this laser, and I will tell you, it treats the eye. I put 3 seconds. It's actually 2.7 seconds. The patient walks up to the laser, puts their chin in the chin rest, speculum is in the eye, and by the time that they can count to 3, the laser treatment is done. It's equally efficacious and has a similar safety profile in a head-to-head study against the traditional SLT. And I think it's really excellent, our addition to the interventional armamentarium, especially for optometrists that are in laser states. Speaking of optometrists in laser states, as someone who is from Tennessee, I have to take a moment to give a shout out to Tennessee on becoming the 16th state to obtain OD laser privilege. I am so proud of our colleagues in that state. This is a chart that docs may want to take a screenshot of, and it's also within the handouts. It's a chart that I made that features every therapy that is currently FDA approved for the topical management of glaucoma, and puts them in drug categories. The intersections are the combined fixed dose, and the colors in the boxes are the cap colors. And as a doctor, when you're diagnosing somebody with glaucoma, you're looking at this chart and you are thinking, okay, out of this, what do I pick? And I really need you to lean in toward the right column, guys and gals. This is where our aqueous outflow is. And if we can focus on the top right corner and the bottom one, the PGA plus nitric oxide, if we're able to work in an area that is where the fundamental disruption of the disease is, which is the trabecular meshwork, I think that we're on the right path to preserving that tissue versus aqueous outflow. I explain, if you have a plumbing system issue with your house, you don't just turn the plumbing off and forget about it. You want to flush it, you want to keep using it and keep it moving. You have to remember that TM is living, breathing tissue, and it requires nourishment, and we should do everything we can to keep it healthy. So think about what you would choose for yourself and your family. Would you put a patient on a 3 times a day medicine, on a twice a day medicine? Would you prefer to be on a once a day medicine? Would you prefer to be medicine free at all if it was you? And if a patient is faced with compliance issues, whether it's within their control or beyond their control, that doesn't matter to us as doctors. The judgment hat needs to stay outside of the clinic. For whatever reason, if a patient isn't able to have access to their medications or remember to use them, it's our job. We are very, very privileged to be in a place where we have the ability to help our patients. And so one of the beauties and joys of glaucoma management to me is figuring out the way to get this patient's pressure controlled to the target in a way that is going to not harm their wallet, to be the most cost effective for them and the easiest for them, especially in this day and age. So we have to address compliance barriers, and it's really important to not discount dry eye disease. My friends in the dry eye world, they're like, you're not going to be able to do a glaucoma lecture without talking about dry eye. I was like, you're right, you're 100% right. But you need to know that symptoms of dry eye disease are a predictor of noncompliance in glaucoma management. I saw that empirically when I was managing glaucoma patients early in my career. I wrote a lot of dry eye drugs early in my career, and I wasn't a cornea specialist. And the dry eye reps came and showed up, and they said, what are you doing writing these dry eye medicines? You treat glaucoma. And I said, yeah, but if I manage the dry eye, patients are more comfortable. Their primary optometrists are happier because they're getting better refractions. Patients are in their contact lenses longer. But then for me, it's a little selfish for me because in the patients, the drugs don't sting when they go onto the eyes, and the patients are more compliant with using their medicines. Speaking of compliance, this is one of the most powerful studies that I've come across. Dr. Rajanala and colleagues did a study where they watched patients put drops into the eyes. And if patients were deemed, they were either effective or non-effective or ineffective. Patients knew that they were a part of a study. They were being filmed with nobody else in the room, just the camera and them and the drops. At 5 years, 100% of the patients that had an ineffective technique, they experienced disease progression. This is so sad because I inherit patients from other MDs even that show progression. They are added drops are on 4 bottles of drops. And I hand them a bottle of Sustain, a little sample, and I say, hey, can you show me how you put this drop in your eye? And within 1.5 minutes, my fears are confirmed that the patient can't even get the drop in the eye. So it's not that the disease was unstable and off the rails. It was that the patient just wasn't getting the medicine in the eye. And that's where these two next items come in. Bimatoprost SR, this is called Durista. It was made by AbbVie, or this used to be Allergan. This Durista is a bioinert polymer matrix. It's like a little baby Alka-Seltzer. It dissolves within the eye, and it is bimatoprost. And it dissolves, and it can be done in the ASC or the exam lane. It lowers the pressure by 30%, which is what we would expect. It's a 1-for-1 swap for a prostaglandin. Anybody that's on a prostaglandin and doesn't have any corneal issues, because you're going through the cornea with a 28 gauge, is a candidate for this. The medication is gone after 3 months. You could do an AC tap at 4 months. There's not a single molecule bimatoprost floating around in the aqueous. But I saw this lasting longer. 6 months, 1 year, 1.5 years. When I was telling patients, you'll probably get about 1.5 years out of this. And then lo and behold, a clinical study was published, a paper that showed that at 18 months, 77% of patients were still drop-free. And this is thought to be due to a long-term remodeling at the trabecular meshwork, a genetic upregulation of MMPs. So a very, very unique mechanism of action that the company was not expecting, but it benefits the patient. So a patient can get a little dissolvable pellet, last about 2 to 3 years. They get a break off of their drops. I love this for patients prior to cataract surgery. They're only on 1 PGA, and they're fairly stable. Get them off their drops for 2 or 3 years. Get that cornea surface primed. Your glaucoma or your cataract specialists are going to be very, very happy for you. And Travoprost TR, this is also a prostaglandin. Again, any patient that's on a prostaglandin and that doesn't have any cornea issues may be a candidate for this. And what this is a teeny tiny little titanium implant. It is 75 micrograms of proprietary Travoprost. So the Travoprost TR has Travoprost, the Durista has bimatoprost, and it is like a little plug that goes into the scleral wall. You can remember this because just like a golf tee that would go down into the ground and push into the ground, this is a little insert that goes right into the scleral wall, and T for golf tee for Travoprost, and time. The time, there's 3 years worth of medication that is inside of these little teeny tiny little implants that are made in the United States and California. And this is a really, really nice option for patients to be drop free. So this is a nice option after cataract surgery. So I honestly think a nice place would be, you can put your intracameral bimatoprost before, keep the ocular surface prime, and then this is the time of cataract surgery or thereafter. So let's talk about cataract surgery and MIGS. And we're in the home stretch. So thanks for hanging in there with me, guys and gals, on a Wednesday night. Cataract surgery and MIGS. This window of time and insurance coverage is precious. Please do not squander it. As optometrists, we play a very real role in determining who these cataract patients go to. Because 100% of the not 100%, I would say 95% of the cataract patients in the United States are in our offices as optometrists. And we have the ability to refer to the surgeons that we trust. There are certain MIGS stents that are only FDA approved to be performed at the time of cataract surgery. One is the iStent Inject W and the Hydrus Microstent by 2 different companies. And these, once this window's gone, it's gone for forever. So if you're only sending to a cataract surgeon, does this cataract surgery alone that does not do MIGS, that tells me how progressive or non-progressive that surgeon is in believing in what's right for the patient. And I truly think that all optometrists should be referring to cataract surgeons that at least know how to do one MIG. Doesn't matter to me what it is, but they need to have one in their toolbox to at least offer that to the patient at the time of cataract surgery. Because for most patients, this ends up being no cost to them. Recently, there were some changes in CMS reimbursement where now docs can't do multiple MIGs at the same time, but they can do one, the one that's covered. And then there are other ones that are approved to be done as standalone, and they can be done at any point in the future. So failing to refer to a surgeon that performs CE MIGs is preventing the patient from benefiting from a safe and effective intervention. So if you look at that map on the right side, if you send to a patient to a cataract surgeon that does CE MIGs, you're keeping them on that smooth path on their journey. You have an idea of where it's going to go. If you don't, and you're just sending to the same cataract surgeon that refuses to MIGS, that refuses to be involved in interventional glaucoma, now the patient is off on that side road and you do not know what's going to happen to that patient with regard to their glaucoma progression. The MIGS, the iStent Inject W and the Infinite, this is the same stent, but it just depends on how many of them there are. The iStent Inject W was a pair, and it was FDA approved to be done as a pair at the time of cataract surgery. But the iStent Infinite is a trio of these stents, and is now approved to be done as a standalone. IOP reduction up to 7 millimeters of mercury, and it doesn't keep patients from going into an MRI machine. Nice data at 12 months and 10 years. The Hydrus microstent is a 7.5 or an 8 millimeter nitinol stent, and it has the ability to reduce IOP to 7.5 millimeters. This is the part of the data set, the Horizon data set, that I want you to focus on. Patients were either given cataract surgery alone or they're given cataract surgery in the Hydrus microstent. And for these patients, those that had cataract surgery with the microstent, they were 60% less likely to require incisional glaucoma surgery. That is a big deal. So MIGS at the time of cataract surgery is becoming the standard of care. So please consider modifying your cataract referral patterns accordingly. And now we're in the home stretch. My battery.
I think Dr. Cothran's computer may have died there. It sounded like perhaps her battery has given out. We'll give her a minute here to see if she jumps back on. I know we do have a few kind of lingering questions here. If she does, otherwise we did hit the 50-minute mark. So I wonder if we could go ahead and put the QR code up. Thank you, everyone, for your patience. We're trying to get the QR code up here for tonight's CE credit. Great. So thank you, everyone, for attending tonight's presentation. A post-event survey and certificate will be emailed to you after the event concludes. And here's the QR code for tonight's event. Please make sure you're using the OE Tracker app when you're scanning the QR code. Please don't just use the camera on your phone if you want to receive instant credit for this evening's lecture. And a special thank you and shout out to Dr. Cothran. Today was her birthday and she was in Puerto Rico, so battling kind of several challenges in terms of internet connection. Really appreciate her excellent lecture here this evening. And, really going into practice with this interventional glaucoma mindset, being proactive instead of reactive, a really important take-home message from Dr. Cothran here this evening. So thank you, everyone, for attending, and we'll see you at the next WU event.